title of our conference this year is Unity and Diversity in Gynecology and Obstetrics. And I think that talking about fetal anomalies is one of the most important branches from the main tree of gynecology and obstetrics. This is a very important subject which raises so much controversies in obstetric practice. And today we'll have distinguished speakers. We'll start by a very dear colleague and actually a very clever ultrasonographer in our department, Dr. Hassan Ghaffar. His talk will be about the incidence of consanguinity in cases of fetal anomalies.
Thank you, Dr. Omar. Thank you, Dr. Ali. It's my pleasure to be here in our annual Congress of our department. And of course, as Dr. Omar mentioned, the congenital anomalies and consanguinity are a very close or very common subject that we face in our daily practice. So this is why we conducted this study that was done in our fetal medicine department in Asr Al-Aini obstetric gynecology department. Of course, the worldwide surveys showed that the incidence of congenital anomaly is a little bit variable between countries, but remains within the range of 1 to 4%. As you can see, it's in Japan it's 1%, in Taiwan it's 4%. In the States, it was, as a study conducted, the prevalence was around 2 to 3%, and in England and South Africa, it's around 2%. These variations, of course, has many reasons. Racial, ecological, economical, and social influences affect this incidence. And in Egypt, the only study that I found, unfortunately, one study only, which was done by Temtemi, revealed that the incidence is around 3% here in Egypt. The WHO divided or categorized the anomalies into 13 groups, and they found that the most common groups of anomalies are the CNS, 30%, musculoskeletal, 20%, and genetic syndromes, 13%. So what did we do? It was a descriptive research design, which was done in the fetal medicine unit, as I mentioned before. We got 300 pregnant women with congenital anomalies, 150 with consanguineous marriages, and 150 with a non-consanguineous marriage, pregnant in a fetus with a congenital anomaly at any reproductive age and no specific gravidity or parity. And the research was divided into two parts. The first part was the ultrasound fetal assessment, including the scanning for anomalies, the amniotic fluid index, the gestational age, the gender, and then a structured interview was done with the pregnant lady, including the socioeconomic data, the medical and obstetric history, and risk factors of congenital anomalies. So what did we get? We found no statistical significance between both groups in all what's mentioned here, the education, the age, and the maternal occupation, husband occupation. But just to stress, although there was no statistical significance, but the patients who were married to a consanguineous husband was illiterate and younger than 20 years. And this is what we usually see, that who gets married to a relative is usually illiterate and very young age. And of course, also there was no significance between the parity and gravidity and interpregnant interval between the both groups. And this means that the effect is purely due to consanguinity, not due to other factors. So this is the most important slide. We found that the first degree consanguinity, as you can see on the left bar, is associated with multiple system anomalies. If you compare this to the second degree and third degree consanguinity, the single anomaly is more, but in the first degree consanguinity, we found that the multiple system anomalies is very common, and there's a statistical significance difference between the single anomaly and the multiple anomaly in the first degree consanguinity. When we studied the affected systems, we found that the CNS was the most common, followed by the musculoskeletal, and the genitourinary and facial came on the third place. But we found that the CNS, the facial anomalies, and the cardiovascular anomalies are more common and assist with a statistical significant difference between both groups. So in consanguinity, we found that CNS, facial, and cardiovascular anomalies are more common than in non-consanguineous groups. As I said, CNS were the most affected, followed by musculoskeletal, and CNS face and cardiovascular anomalies were more common in the consanguineous groups. The age group was between 22 and 31 years, and as I said, multiple system anomalies were significantly more frequent in association with first-degree consanguinity with a p-value less than 0.05. This, of course, agrees with some studies done in Kuwait, which revealed the same result. Also, a study done in the United Arab Emirates revealed the same results. We'll see that most of the studies are done in Arab countries because the consanguinity rate is higher than worldwide. Also, of course, in Israeli Arab, we know that in the Jewish, usually the degree of consanguinity is very high between them. So the 68% of the fetuses with anomalies were of first-degree cousins. Of course, another important point that we got, that 29% of these patients gave a history of a previous child or a previous fetus with congenital anomaly. So this means that the recurrence rate in consanguinity is very high. This, of course, was confirmed the results done by El-Komi in Egypt, which also revealed the same result. CNS, followed by musculoskeletal system, as I said, and genitourinary was very high in both groups. And in the consanguineous group, the face, CNS, and cardiovascular was very high. Also, in Pakistan, Jahangir reported that the most common anomalies was CNS, musculoskeletal system, and GIT. And in Iran also, they found that the musculoskeletal followed by the genitourinary and CNS were the most common. Of course, you'll find some differences between the categorization or the priority or the incidence of different systems according to the study groups, which this has to be difference between countries, I think. In Egypt here, El-Komi studied that another study showed that the musculoskeletal, not the CNS as we got, was the higher, followed by the CNS in the second place, and gastrointestinal also within the third place. So the results are more or less near. So to conclude, consanguinity was associated with anomalies involving different body systems, mainly CNS, musculoskeletal, and genitourinary. Anomalies of the CNS, face, and cardiovascular system are commonly associated with consanguineous marriages. The multiple system malformations were significantly associated with first-degree consanguinity marriages. And to recommend, a premarital examination for consanguineous marriages should be encouraged, of course. And antenatal care is very important in suspecting and early detecting these anomalies and terminating pregnancies with lethal anomalies early on, before the 120 days, if we are talking about some Islamic perspectives. The education programs should be established in order to improve the health provider knowledge about the prevalence and risk factors for congenital anomalies. And further studies, of course, are needed to investigate the risk factor of each system anomaly. I just want to take just 2 minutes, so not to be very pessimistic in the issue of consanguinity. I'll just tell you a little story that I got to know. I know a couple who were second-degree consanguinity, okay? And after 10 years of marriage and delivering 3 children prematurely with IUGR, with unexplained neonatal death following birth, one in England, one in Egypt, and one in the Saudi Arabia. And most of the doctors worldwide, they said that delivering a healthy infant will be impossible for this couple, and they have to either get married to another couple or do nothing, try not to conceive again. And after 10 years of marriage, they got 2 children. The elder children of them is the one standing in front of you. It was in 1976. So there is hope always. Thank you very much.
Thank you, Dr. Hassan, for this talk. I think we reserve the questions till the end of the session. Now, my dear colleague, Professor Ali Samari, will introduce the second speaker.
Bismillah ar-Rahman ar-Rahim. Dear colleague, Dr. Luay Zaid, today we'll talk about phenotypic discordance of monozygotic twins. And he has a very nice case about monozygotic twins with discordance.
Mr. Chairperson, distinguished guest, good morning, and I would like first to thank you for allowing me this great opportunity to participate in your distinguished meeting. Today's topic will be about monochorionic twins who seem to be unidentical. Well, twin pregnancies, they occur naturally at approximately a rate of 1 to 90 according to Helen's law. However, the widespread availability of assisted reproductive technologies have dramatically increased the prevalence of and the incidence of multiple pregnancy rates. And many outcomes of multiple pregnancy, as we all know, are greatly influenced by the chorionicity. As you can see, any cleavage of the embryo, of the human embryo, beyond day 3 post-fertilization will inevitably lead to a monochorionic gestation. The accepted origin of monozygotic twins arises from a single fertilized ovum. This implies that their genetic constitution should be identical. And the monozygotic twins are often presumed to be genetically as well as phenotypically, common sense, identical, as they nearly share all of the genetic variants as well as a common intrauterine environment in a way or another. And although popularly designated as identical, the monozygotic twins were found to be rarely identical. And a variety of mechanisms have been described in an attempt to describe this discordance. Well, one of the important mechanisms that it seems that a critical mass of cells is necessary for normal development and differentiation. Unequal allocation of blastomeres to the two embryos may be one of the important mechanisms responsible for the discordance and perhaps for the excess of malformations observed in monozygotic twins. Some genes might be active in one twin but not in the other one, thus being identical genetically but not epigenetically. And among most important reported causes of this discordance, they include the mosaicism for chromosomal or single gene disorders, skewed X chromosome activation, genomic imprinting differences, uniparental disomy, and asymmetric transmission of mitochondrial DNA. Structural anomalies are more frequently observed in twins as compared to singletons. However, the frequency of malformations in dizygotic twins is thought to be similar to that of singleton, around 2 to 3%, while it has been reported to be 2 or 3 times higher than this prevalence in monozygotic pairs. Well, the aim of the current work was to describe a series, this is a case series actually, of monochorionic twin gestations discordant for phenotypic anomalies unrelated to twin anemia, polycythemia sequence, or twin-twin transfusion syndrome. Case of monochorionic twin pregnancies discordant for the presence of fetal anomalies were identified in our center between the years of 2011 to 2014, 3-year time period. The ultrasound equipment used was a Volison E8 Expert, and a variety of details including patient's history, gestational age diagnosis, ultrasonographic findings mainly, details describing the anomalies, and the antenatal course and pregnancy outcome whenever accessible. The prevalence, a total of 23 monochorionic gestations were observed. Among these, 11 cases exhibited phenotypic discordance with an astonishing prevalence of 47.8%, which is against all odds and against all numbers present in the literature, but the explanation is yet to come. Well, I had the privilege to participate with Professor Ville and Professor Salomon in France in conducting this important research, or this interesting research. This was actually a large retrospective study between the years of 1999 and 2011. This is a 12-year time interval, and we found around 45 monochorionic twin pairs discordant for phenotypic anomalies. 45 cases in a 12-year time period. This is 3.75 cases per year. In our series, we have 11 cases in 3 years, so it's more or less the same. So whenever you are conducting or running a fetal medicine center, you have to know that you will bump into a monochorionic pair discordant with phenotypic discordance at a point or another for around 3 to 4 times a year. The average maternal age in our series was around 32 years, and the average maternal body weight was 79.6 kilograms. And all pregnancies were issued from ART-XC cycles. And this is probably the explanation for the very high prevalence of the phenotypic discordance among the monozygotic or the monochorionic pairs observed. These are actually the anomalies. The average gestation age at diagnosis was about 15 weeks and 6 days, ranging from 10 weeks, 4 days to till 23 weeks and 6 days, but most of the cases were actually identified in the first trimester. The first trimester diagnosis actually was in 7 out of the 11 cases, giving around 63% detection rate in the first trimester. This is actually the distribution of the different anomalies observed, and we'll take them one by one. The most commonly observed anomaly was actually the omphalocele. If you can see the monochorionic twin on the left side, during this axial scan, top to bottom axial scan, you will notice that we have an omphalocele in here. Actually, we are now at 12 weeks, 1 day, so this is not a physiological hernia. You can measure it easily in a 2 days, in a sagittal and a parasagittal 2D section. You can use the 3D just to enlighten and to enhance the demonstration of the anomaly, where we can see the lump and the cord insertion. The 4D will actually show you the lump at the belly of the baby, which is the omphalocele. It seems it's not very happy because the other one is dancing, this one is not dancing. And the TUI enhanced with volume contrast imaging, you can see the anomaly clearly in a sagittal plane as well as an axial plane where it is actually evident in different slices at different levels. There are many studies actually correlating the transverse diameter of the omphalocele sac to the transverse diameter of the fetal abdomen as a prognostic indicator. The right aortic arch. Actually, for a long period of time, the first trimester fetal heart was not actually, was seen as being inaccessible. These are first trimester fetal hearts actually with different modalities, stick modalities and surface rendering modes. And actually you can use the TUI to navigate through from for demonstration purposes from 4th chamber view up to the three vessel and trachea view. And you can actually see the ductal arch and the aortic arch dorsal and posteriorly and laterally. So it seems that the first trimester fetal heart is not actually that inaccessible. However, this was a case of right aortic arch. As you can see, the ductus arteriosus and the aortic arch with the vascular ring behind, which is not very clear in this clip, unfortunately, behind the trachea. The next anomaly was actually a single umbilical artery. As you can see, those two twins. In one, we have the urinary bladder with one single umbilical artery coursing alongside of it, while the other one, you can clearly see the normal appearance of the two single umbilical arteries. The single anomaly was a small bowel obstruction. As you can see at 21 weeks, you can see the fetal stomach, which is a little bit dilated for age, and you can see some small bowel dilatation, which is actually not enough to take a decision that you have something wrong. And a follow-up at 28 weeks, you can see the stomach up in here, okay, and you have this huge segment of duodenojejunal dilatation. You can see it actually here on the TUI with volume contrast imaging. This is the stomach with excessive peristalsis. You can see the pylorus in here and the distended bowel loop, small bowel loop, which is clear in a different view here, the distended duodenojejunal loop. Actually, using this Doppler, you can see that the stomach is actually emptying its content with the Doppler, the red sign, but shortly thereafter, you can see that there is actually a massive regurg back to the stomach, denoting that there is a distal obstruction. The next anomaly was actually a labioalveolar cleft. As you can see in the skeletal rendering mode, you can clearly visualize the labioalveolar cleft, and the TUI, you can see it in different slices, actually, the labioalveolar cleft. This is the placenta, the monochorionic placenta. These are the twins, and this is the labioalveolar cleft. The next anomaly was actually a little bit aggressive. This was a body stock anomaly. The body stock anomaly actually is a rare one, with a reported incidence ranging between 1 in 14,000 to 1 per 31,000 pregnancies in large epidemiological studies. So it's a little bit rare. And it is characterized by severe clefts of the abdominal wall with absence of or very small umbilical cord, or it is continuous with the placenta. As you can see here, you can see that the baby is actually tethered to the uterine wall and the placenta with a large degree of scoliosis, and this ventral defect with actually most of the bowel and a large part of the liver actually exteriorized outside the abdomen. The surface rendering mode actually gives you a hint about the problem, the size of the problem, and this is the postnatal picture. As you can see, the cord, which is actually very short and nearly absent, with the major defect and exteriorization of the liver. The pentalogy of Cantrell, as this first trimester fetus is telling us, the pentalogy of Cantrell is actually an anterior abdominal wall defect combined with a diaphragmatic defect, absent lower sternum, absent pericardium, with ectopia cordis with congenital cardiac defects. In this first trimester fetus, you can see in the surface rendering on the right-hand side of the screen, you can see the fetal brain actually, and the fetal face with the ectopia cordis seen just below it. At 21 weeks and 6 days, you can clearly see that the fetal heart actually lies outside of the chest. And I would like to draw your attention to the stomach, which is lying intrathoracically, denoting that this is actually a associated diaphragmatic hernia. And this is the postnatal picture, actually, which is quite striking. The pagus. Actually, as we have mentioned earlier in this lecture, beyond 3 days you have a monochorionic gestation. But actually cleavage after formation of the embryonic disc, of the bilaminar embryonic disc, which takes place usually by the day 12 post-fertilization, if you have any cleavage taking place beyond the 12th or the 13th day post-fertilization, you'll inevitably have a conjoined twin, or Siamese twins. This is actually a nice diagrammatic representation of the neural spectrum of the neural tube defects. In this particular case, we'll be interested to the anencephaly case, the exencephaly-anencephaly sequence. If you can see in this first trimester skeletal rendering mood, you can see 2 spines, you can see lots of ribs, 2 thoracic cages. You can see an ossified vault on the right-hand side, but you get nothing on the other one. Now let's see the 2D clip. As you can see, you can clearly delineate 2 spines converging. You can see an ossified calvarium, and on the other side you can see actually the orbits of the baby, of the fetus, the fetal orbits, and exteriorized brain tissue. So this is actually a conjoined twin. However, you have one with normal skull and the other one with exencephaly and anencephaly sequence. This is actually a quite challenging case. This was the last and challenging case. This was actually a triplet pregnancy, triplet pregnancy, dichorionic triplet pregnancy. But while scanning one of the fetuses at 20 weeks and 4 days, if you can see, there's this small physiological hernia, no problem. But if you focus a little bit more while scanning the baby, you can see there is a lump just next to the fetus. So we decided in a sagittal plane, you can always see the physiological hernia. And if you can see in here, you can see the lump again in a sagittal view, still no clue to the diagnosis. If you check in this part, in this coronal view, you can see that this lump actually carries a humanoid feature with a vestigial head and a vestigial body. If you focus a little bit about the Doppler signal, you can see that this is the umbilical artery of the bigger twin, of the big baby lying on his side, this one, which is pulsating at a normal heart rate. You can see this descending aorta of this vestigial fetus, which is pulsating at exactly the same heart rate, and a vestigial cardiac structure which is actually pulsating at a much slower rate. This is not all. Please pay attention that my probe lies down, which means the blood is flowing in a retrograde direction in the descending aorta. This is a twin reversed arterial perfusion sequence, or commonly known as the trap sequence. As you can see here, this is the bigger twin. This is the bigger twin with his umbilical cord inserted in the placenta, and this is actually the small one, the small vestigial one, with his umbilical cord with actually a single umbilical artery eventually inserted in the same placenta. Pregnancy outcome, actually both fetuses were well in 28% of the cases. Eventually these were actually the common sense, the omphalocele group. The reduction, 9%, terminated 9%, no available data in 18%, neonatal death 9%, failed cord occlusion 9%, and preterm delivery both died at 18% in 18% of the cases. Well, to conclude, morphological discordance in monochorionic gestations is not exceptional. In the current series, pregnancy issued from ART, ICSI cycles are apparently at a higher risk for developing this problem. Omphalocele lies at the top of the described anomalies in this current series. Meticulous ultrasound examination of both and not only of one co-twin should be performed in all cases. I hope I didn't bore you. I hope I didn't give you a bad headache, and I would like to thank you. Questions at the end of this?
Thank you, Dr. Luay, for this very interesting presentation. And now, may I call for a very distinguished professor, Professor Muhammad Ali, who is one of our distinguished professors in the field of ultrasonography and prenatal diagnosis. He will give us a talk about CNS anomalies causing fetal seizures. Dr. Muhammad.
Thank you very much. Professor
كنت
Dr.
عايز بس اسالك سؤال قبل ما تبتدي معلش. Do you mean CNS anomalous causing fetal seizures or neonatal seizures?
There is nothing called fetal seizures, of course, and it was wrong from the transmitters. So now, first thing, I would like to thank Professor Dr. Omar for this introduction. And secondly, I would like to congratulate myself and congratulate our department for the success of this conference. And it's an honor for me that this is the 14th consecutive time in which I share as a speaker in our conference, and I hope this continue in the next year. When I choose a topic for a conference, I try to make it of clinical importance. And actually, I try to put some sort of topics which the clinician do care for its importance. For example, when a clinician read a report about some problem in the fetal CNS, I found it very difficult or very tough that the patient ask him about the future of that fetus, what's going to occur after delivery for the neonates, and he cannot say, I don't know, because she puts all the trust of him. Therefore, our role is to try to throw the light